Good afternoon. It's great that we can all meet today to explore the topic access to mainstreaming germline BRCA genetic testing in early breast cancer. My name is Dr. Teh Mezi and I am a consultant breast surgeon at University Malaya Medical Center, UMMC, Kuala Lumpur, Malaysia. This is a hybrid meeting with physical audiences and also live broadcasting for virtual participants. To date, we have about 150 participants from all around the globe. For those who are accessing virtually, kindly let us know in the chat box if you could not hear or see us. Today's session will be split into two segments, each lasting for about 45 minutes. We will have a 30-minute lecture followed by a 15-minute panel discussion or Q&A session for each segment. The first segment is about the changing indication of germline BRCA testing, and the next segment will be on integrating germline BRCA testing into routine clinical practice. Breaks are planned for about 10 minutes between these segments. We will address some questions during the panel discussion. In case of any technical issues, please signal us in the chat. We will try to help you resolve it quickly. And now we can begin. The demand for genetic testing of hereditary breast cancer genes, such as BRCA1 and BRCA2, has continued to increase with the lowering cost of testing, raise awareness in the general public, and implications for breast cancer treatment when a patient is identified as having a germline pathogenic variant. Development of novel treatments for breast cancer that occurs in individuals with a germline pathogenic variant has caused a paradigm shift. These treatments include decisions around the usage of platinum-based chemotherapy for triple-negative breast cancer, roles of contralateral risk-reducing mastectomy at the time of initial surgery, and PARP inhibitor to treat metastatic disease. However, the recent practice-changing results of the Olympia trial underscore the importance of identifying germline BRCA mutation carriers among early breast cancer patients who may benefit from PARP inhibitor in addition to those with advanced disease. This brings us to our topic today, access to mainstreaming germline BRCA genetic testing in early breast cancer. Without further ado, I will introduce our first speaker today, Professor Yoon-hee Park from Samsung Medical Center, Korea. Professor Park is a medical oncologist who is well known in the field of breast cancer with an extended list of research and publication. She is the lead for several genomic studies with a focus on refractory and young breast cancer. It is fortunate for us to have her deliberate on the topic, Rethinking Adjuvant Treatment Strategy, PARP inhibitor as novel targeted therapy in early breast cancer. With this, let's welcome Professor Park.
Thank you very much for your very kind introduction. I'm Yeon-hee Park from Samsung Medical Center, Seoul, Korea. Good afternoon, ladies and gentlemen. It is great pleasure for having me here to present this topic. So I thank you very much for inviting me to be here to present this topic. I'll talk about entitled Rethinking Adjuvant Treatment Strategy, PARP1 inhibitor as novel targeted therapy in early breast cancer. Next slide, please. So here's my disclosure slide. And then next slide, please. So you are very well known about the prognosis of breast cancer. Breast cancer is a well-known cancer disease, have a relatively very good prognosis, but many early breast cancer patients still experience recurrence, and some group regarded as a high-risk group. So up to 30% of early breast cancer patients with high risk clinical and pathogenic pathologic feature may experience distant recurrence within a few treatment of years. As you can see here, so according to the subtype and also the disease stage, so, and grade, you can find out here the recurrence. So a number of factors increase the risk of recurrence, including high tumor and nodal stage and high tumor grade and certain histologic subtypes. Next slide, please. So, if so, previous slide, please. So, who are at risk, high risk of recurrence with early breast cancer? Today's topic is really in here. So several clinical and pathologic features are associated with high risk of recurrence. You can see here across the early breast cancer patient population. So most representatively the staging system, as you can find out here. So also in case of the population who received neoadjuvant chemotherapy, when they fail to achieve the PCR, it turned out to be a early recurrence or bad prognosis, irrespective of the subtype status. Now we can also use the high CPS score, CPS and EG score, so clinical pathologic scoring and estrogen grade score. And also you can be very familiar with the luminal breast cancer with this germinal test, Oncotype DX mamma print like this. Next slide, please. So according to this higher CPS and EG score, you can find out here. So it's a well matched the long-term outcome. You can find out here. If the patient have a higher CPS or EG score, so it means the early recurrence and the bad prognosis in terms of disease-free survival and also breast cancer specific survival. Next slide, please. Let me move to our today's topic is BRCA 102. You may very well know this very famous American actress Angelina Jolie. I think she's the real propaganda for the preventive breast cancer mastectomy, who harboring breast germline BRCA1 or 2 mutation carrier. So it's from her painful earlyhood memory. So she has her mother and her aunt passed away because of the breast cancer when she was a teenager. So that makes her do the preventive both mastectomy and also bilateral salpingo-oophorectomy. So I think I take this opportunity. She's a kind of propaganda pioneer to propagate the preventive breast surgery or the ovarian surgery. Next slide, please. You also very familiar with this hallmark of cancer. Among them, today's topic is genome instability. In other words, the HRD, homologous recombination deficiency repair mechanism. And next slide, please. And real good target we can have today, PARP1 inhibitor. Next slide, please. Also, this opportunity to accelerate also tissue agnostic approach. So under the contrary of traditional drug development model, the traditional phase 1, 2, 3 model, now so many other platform is a real innovative clinical trial platform such as the umbrella trial and basket trial, most representatively best among whole basket trial is a real PARP1 inhibitor and HRD is a real tissue agnostic approach. Next slide, please. So you can find out here. So there is unmet medical need in patients with BRCA germline mutation carriers or early breast cancer with a certain group as substantially high risk of recurrence. Usually, patients with germline BRCA1 or 2 mutation, pathogenic mutation carrier are younger at diagnosis and higher tumor grade and more contralateral and ipsilateral disease, and also very higher affinity of CNS metastasis. I can share with my slide for the time studies, but it's a little bit conflicting study result up to now. The study did disagree whether the risk of breast cancer recurrence is greater in patients with germline BRCA mutation carrier or in those with sporadic early breast cancer. Is still ongoing debate. And there is an increased risk of secondary breast cancer or ovarian cancer in germline BRCA mutation carriers. All these study result conflicting result and also this impact on overall survival. But can a patient with germline BRCA1 representative of a distinct population and the ability of targeted agent olaparib, its PARP1 inhibitor, to improve outcome for patients with germline BRCA mutation had been investigated and confirmed through Olympia clinical trial. Next slide, please. So patient with germline BRCA1 or 2 mutation early breast cancer has also distinct tumor characteristics compared to the non-germline BRCA mutation populations. So patient diagnosis at very younger age, I can share with you. In BRCA mutation tumors are higher grade and more affinity and much more affinity in CNS metastasis. And also at the same time, so more contralateral and ipsilateral disease, which makes many patients receive preventive mastectomy also, and higher risk recurrence. Next slide, please. So then we can estimate the population who may have a germline BRCA1 or 2 pathogenic mutations. There are many other data, and up to now, 5 to 35% is a very wide range of germline BRCA1 mutation carrier. And also in Western countries, usually, except Jewish people, it's a very rare kind of carrier disease. But I think the Asian population is much more common in terms of germline BRCA1 or 2 mutation carriers. So it's from our institutional data. In unselected TNBC population, we found the germline BRCA1 or 2 mutation is up to overall 13.1%. If the age limited less than 60, 14.5% is much more higher than expected. And also you can find out here the proportion of the germline BRCA1 harboring patient population is earlier, much more germline BRCA1 much more found in earlier population. Next slide, please. Is another data set from our Korean data set. Is prospectively collected by Korean Cancer Study Group Breast Cancer Committee. Because of we really want to know if the patient who are not at risk, not at high risk of germline BRCA2, because the Korean reimbursement system is the reimbursement system only care about this high risk patient, age less than 60, and family history of relevant cancer or bilateral breast cancer in case of TNBC population, and also hormone receptor positive, HER2 negative high risk population is less than 40, like that. So except the population, we prospectively collected all the 560 patient HER2 negative MBC population in unselected. You can find out here, so even in the low-risk population, in TNBC population, 10% of population show the BRCA1 or 2, but they are very unknown until we do this test. So we may expand the test to more wider population. And also very uniquely, even in the low risk population, HER2 positive, hormone receptor positive, HER2 negative breast cancer showed a 5.4% of germline BRCA1 or 2 mutation carriers. It's a really relatively high than expected. So we now is a really good time to expand the test to more wider population because we need to select the population who may benefit from PARP inhibitors. Next slide, please. And it's another population. It's also Samsung Medical Center Young Breast Cancer Cohort 2. Since 2013, we have a kind of it's a multidisciplinary clinic. So our surgeon and also the me and the pathologist and radiologist and gynecologist and plastic surgeon. So it's a multidisciplinary clinic. Since then, we can collect the young breast cancer population prospectively like this. Up to now, among 2,000 of young breast cancer, less than 40 patients collected in this prospective cohort. We can collect also the genomic data also. Among them, so you can find out here is I showed the characteristic table according to the germline BRCA1 or 2 status. You know, 41 less than 41 means the older patient can be reimbursed umbrella to test germline BRCA1 or 2. So older patient can be tested under the umbrella of reimbursement in Korea. So older patient tested germline BRCA1 so in overall population, so 10% of germline BRCA1 prevalence was shown. Limiting to TNBC, 18%. And hormone receptor positive HER2 negative is 9.1, pretty much more higher than the older population. So we can find out this here, and also you can see the table when you compare to the BRCA group versus non-BRCA group. You can find out here some more higher incidence of the family history of breast cancer, and also the TNBC predominant enrichment population, like here, and more higher Ki-67. Next slide, please. So now let me share my Olympia trial experience. So during the Olympia clinical trial in SMC, 29 patients were randomized. And among them, 5 patients recurred. Which means that 70% of a patient recurred up to now. But it's a kind of it's a coincidence or not. You can exactly witness the higher incidence of recurrence in placebo group. During my preparation of this lecture, I also confirmed all the progressed recurrent patients were placebo group. The AstraZeneca at that time, when the patient showed the recurrence, they allowed to unblinding for next treatment. So that's why I have a patient who unblinding and turn out to be placebo group, and all the patients who progressed from the trial turn out to be placebo group. Next slide, please. Let me share here the 5 patients of Olympia trial. During preparation of this slide, among 5 patients, 2 patients remind me a very sad story of my patient, and among 5 patients select today, 3 patients experience recurred and 2 patients are still ongoing. And first, third, 3 patients experienced recurrence and 2 patients passed away because of the disease. The first patient was the female, 34 patient. Actually, she diagnosed as a triple negative breast cancer. Our institution usually clinical stage 1 MOA and also nodal stage 1 in TNBC population, usually we can treat it with the neoadjuvant chemotherapy. And 2019, at that time, we usually treated with the AC followed by docetaxel regimen. Now, we can treat it with weekly paclitaxel plus carboplatin plus pembrolizumab followed by AC, but at that time we treated with standard of care with AC followed by docetaxel. And then she received the surgery, but as a non-PCR, as you can find out here. So she enrolled the Olympia trial, but after 3 years and 5 months, her disease-free survival at the time, 3 years, 5 months, her disease occurred. At that time, the unblinding were allowed and turned out to be she received placebo treatment. Fortunately, her disease is still localized disease, and then after at this time she received bilateral total mastectomy, and then as a adjuvant treatment, paclitaxel carboplatin received and still follow up without evidence of a disease. Next slide, please. Fortunately, we have a somatic genomic test, cancer scan. We call it cancer scan in Samsung Medical Center. Samsung Genomic Institution have a genomic test at that time. So we have 3 times of targeted sequencing data from her disease tumor. So you can find out here, so except BRCA1 splice citing mutation, you can find out another mutation like this here, and pretty consistent throughout the period, and also when her disease occurred, so another recurrent mutation developed, you can find out here. Limiting to homologous recombinant deficiency gene, except BRCA1 pathogenic mutation, her tumor showed the BALD1 and also BALB2 and BRCA2 mutation in her tumor. So it gives us a kind of a lesson when we do the targeted sequencing from the patient with who harboring BRCA1. So it's a recurrent BRCA mutation in her tumor and also other homologous recombinant DNA related gene mutations. Next slide, please. Next patient is also reminded me of a very painful memory. She is 30 years old when her diagnosis disease, and actually when she diagnosed breast cancer, her older sister just passed away because of breast cancer. So she is a kind of also the depression and also anxiety mood. When we do the germline BRCA1 or 2, the BRCA2 pathogenic mutation, at that time, just postpartum period with her second baby. So she diagnosed as a bilateral breast cancer. Left is actually surprisingly, she can have a lobular carcinoma. And right breast cancer as a DCIS. And we also have at that time cancer scan data. I can share next slide. And then at that time, she received the AC followed by docetaxel as a adjuvant chemotherapeutic regimen. And then you can find that here just not non-responsive to chemotherapy. It's still higher tumor burden, and we do the radiation and also tamoxifen, also the enrolled to Olympia study. So next slide, please. So you can find out here, so her disease show the lobular carcinoma feature. Relatively, lobular carcinoma were found as more common in BRCA2 mutation carrier compared to BRCA1 disease. And also her disease is even in the lobular carcinoma, abruptly progressed leptomeningeal seeding. So she is the first recurrence placed the CNS, and furthermore, retromeningeal seeding without any other evidence of the extracranial disease. We do the ITMTX, like next slide, please. Next slide, please. Like this. We use previous slide, please. Yeah. So like this, and repeatedly do the ITMTX, but we cannot control her IICP, and then ventricular peritoneal shunt were performed and whole brain radiation. And for at that time, so turned out to be her disease received also the placebo. And then finally, after several cycles of cytotoxic chemotherapy, she had the opportunity to receive Talazoparib as a compassionate use program at that time in Korea. But anyway, she passed away because of a CNS disease. So overall, her disease lifespan only less than 30 years after her disease recurred. Next slide, please. It's a from her tumor tissue. So you can find out here, so except BRCA2 frame shift mutation, also additional other mutation were found in her tumor, and also total PTEN loss were found. Maybe her disease deteriorated course related with the PTEN loss, and also this PTEN loss related maybe tumor suppressors in non-function, I mean BRCA2 mutation, and also limiting to hormone HRD mutation gene. So BARD1 gene also mutated in her tumor. Next slide, please. And the third patient is also it's a painful memory also with me. So 34 patient is a triple negative patient, and her germline-1 pathogenic mutation carrier. She also received the neoadjuvant chemotherapy, but it's a primary refractory disease. So less than 1 year through all the adjuvant treatment, and also she enrolled the Olympia trial, but her disease came back on her own. At that time, the unblinding were allowed. It also turned out to be a placebo. And then she enrolled another clinical trial, Beliparib, and a trial, Brightness trial, but it's only eight months of progression-free survival. At that time, also the progression occurred. They allowed to unblinding and turn out to be a placebo. At that time, I feel very bad for her because she enrolled 2 times of a PALPON trial, but both of trials she only received the placebo. Anyway, her disease, even the treatment of platinum agent, her disease occurred from the brain. The gamma knife surgery and also systemic treatment were repeatedly done. Finally, after third regimen, she received olaparib and durvalumab also, because at that time she enrolled the Mediola trial. So phase 1 trial is a 2-test, olaparib plus durvalumab for BRCA102 regime harboring patient. But as you can find, just 2.5 months of a progression-free duration. And finally, she passed away her disease progression. So I think it's like, what if she received the olaparib as her adjuvant treatment? And also, what if she received the Beliparib as her first-line treatment? I feel very bad. That reminded me her. So this time, during my preparation of this slide, it reminded me of my like a painful story. Next slide, please. So you can find out here how the CNS disease, very high intracranial pressure and repeatedly gamma knife surgery and also systemic treatment, but failed to have a durable remission. Next slide, please. Let me share the next two patients who still NED, so no evidence of disease follow-up. Why I choose these two patients? I reviewed her both of them medical record through, and then I found it out that is a serious neutropenia and also transfusion history when we when they enrolled the Olympia trial. Maybe it's an unblinding state still, but maybe because of their serious toxicity history, they might receive the olaparib, not placebo, and still ongoing treatment without any disease evidence. So triple breast cancer, 34 patients. All the 5 patients is mid-30. It's a real bad situation, and BRCA1 pathogenic mutation carrier and triple negative. And also she received AC followed by docetaxel and paclitaxel cisplatin as their adjuvant treatment. And then after treatment, she disease showed non-PCR, and then she can enroll the clinical trial, enrollment Olympia trial, and then now just to follow without any treatment. Next slide, please. My last patient is also BRCA2 pathogenic mutation and ER positive, HER2 negative, 35 years old, also very young lady. And she, despite of her neoadjuvant chemotherapy, her disease burden very huge. And then can enroll the Olympia trial. Maybe she received olaparib because of her several times of transfusion history and also serious neutropenia. So next slide, please. Let me fastly move to the, so you already know that it's the Olympia trial study. They enrolled this high-risk neoadjuvant adjuvant population with the CPS-ES score. Next slide, please. So you can find out here, so in terms of disease-free survival, you can find out your hazard ratio is 0.58 and remarkably significantly improved survival showed in the olaparib group compared to the placebo group. Next slide, please. So longer period also the similarly consistent with hazard ratio 0.63. Next slide, please. And also the another over 7% of more patients treated with adjuvant olaparib were free of dysentery at 3 years. Next slide, please. So from that trial, NCCN, next slide. Next slide, please. And ASCO also. And next slide, please. Same guidelines, all the global guidelines recommended strongly induced adjuvant olaparib for patients with stage 1 or 2 or 3 HER2 negative breast cancer population, so eligibility criteria. Next slide, please. So maybe detection of germline BRCA significant impact of patient care plan, as you can find out here. You may agree that. Next slide, please. So, but I think the CPS score is not enough to do that. Next slide, please. So more patients may have germline BRCA1 or 2 and who can benefit from olaparib treatment. Next slide, please. And more population germline BRCA found in hormone receptor positive disease. Next slide, please. So can Olympia population may not enough to the olaparib treatment. Next slide, please. So, and you can also find the hormone receptor positive high risk population. Next slide, please. And more oncotype higher score were found in germline BRCA1 or 2 carrier in hormone receptor positive HER2 negative population. Next slide, please. And also, we can experience more poor prognosis to CDK4/6 inhibitor in case of germline BRCA1 or 2 mutation carrier. Next slide. Next slide. Next slide, please. Next slide, please. And we can have another kind of a computer in complex situation to adopt Mullaphari monarchy trial for almost a positive population. And then next slide, please. Next slide, please. And next slide, please. And also Keynote 522 trial for TNBC population. So let me move to final slide. Next slide, please. So it's my final slide. Previous slide, please. Germline BRCA testing should be extended, but for whom? And then feature gene panel test appropriate for screening, and somatic HRG signature using NGS should be defined, and current definition of high risk optimal. We can have a good question today. Let me stop here. Thank you very much for your listening.
Thank you, Professor Park, for the enlightening talk. Kindly stay on for our next panel discussion. We will now move on with a Q&A in our first panel discussion. Let us welcome our moderator, Ms. Yoon Sok-yi, to the stage. Ms. Yoon is one of the only few certified genetic counselors in Malaysia. She obtained her credential as a Fellow of Human Genetics, Society of Australasia, FHGSA, in 2004. She was previously the primary investigator for the nationwide mainstreaming for genetic counseling study for ovarian cancer called the MAGIC trial. She is currently a visiting genetic counselor in UMMC, Cancer Research Malaysia, and several other private hospitals. I would also at the same time like to welcome our panelists. Our panelists would be Professor Park, who was the speaker just now. And next, we will also welcome Dr. Senia binti Muhammad Sikin from Hospital Sultan Ismail, Johor Bahru, Dr. Nur Adila Mokhtar from UMMC, and Dr. Kylie Loh Wei Jen from Penang Adventist Hospital, who will be with us virtually. Dr. Senia is a consultant breast and endocrine surgeon of Hospital Sultan Ismail Johor Bahru, obtained her medical degree in 1999 and her Masters of Surgery in 2008 in UKM. She finished her subspecialty in breast and endocrine surgery in MOH and also Newcastle University, UK. Dr. Nur Adila Mokhtar is a clinical oncologist in UMMC who have completed her medical degree in Sheffield, her MRCP and FRCR in UK. She completed her specialty training in UK and was previously the consultant clinical oncologist at Western Park Hospital, Sheffield. Her special interest is in breast, genitourinary, lung, and gynecological cancer. Dr. Kylie Loh is a breast medical oncologist from Penang Adventist Hospital and Curie Oncology, Singapore. He graduated from the University of Melbourne, trained in medical oncology with the Victorian Medical Oncology Training Program before subspecializing in breast cancer at the National Cancer Centre, Singapore. I will hand the next session to Ms. Yoon.
Thank you very much. Thank you, Dr. Tay, for that kind introductions, and welcome to this discussion to our panel of distinguished guests, panelists. So we had thank you very much, Professor Park, for a very thorough and introduction to how the use of germline BRCA information is moving on into the treatment space. So starting from that, I there are some questions, but let's start with one for Professor Park first. So, with the changing landscape of how germline BRCA information is used now towards treatment decision making, when do you think the discussion about germline testing for breast patients should start? Very early on upon diagnosis, and in your experience from the oncology setting, what opinions do you have of that?
I think it's ASAP, I think. So usually in our institution, when she diagnosed as breast cancer, we after just after that kind of early diagnosis and first diagnosis, she can have a kind of a genetic counseling, and then just to test the germline BRCA1 or 2 when she kind of a category of our reimbursement umbrella, we do the germline test.
Yes, that's right. In the situation in Korea, especially when it has to do with reimbursement under health service, and I suppose that's when the information about guidelines on who to test and why the patient is being tested for, that is also changing rapidly as well. So does that mean that the discussions will start early at diagnosis in both the surgical side and also if they're seen at the oncology side? Is that what's happening now in Korea?
So usually the first diagnosis was done at surgery department. At that time, at the same time, she received the genetic test.
Okay. So
Yeah.
very quick, very early on.
Yeah.
All right. So thank you very much for that. Let's take a look at situations here in Malaysia. And perhaps now let's have some opinion from Dr. Sania. So from the surgical point of view, now because again the movement of having the testing is towards a treatment, so from the surgical side, how do you think that fits into your clinical pathway? Because maybe most of the patients would see you first in that sense. How do you think that's going to fit into your discussions with your patients?
Assalamualaikum and good afternoon. Thank you for the question. So basically, I'm working in the southern of Peninsular Malaysia. So we will cover all the southern state area. So basically, they have few district hospital will come over to us. If they have any problem with the patient, they will refer to us. We are breast endocrine center in a southern area. So for the genetic study, basically it's very limited. It's very limited, and it's in terms of education is one thing that we have to educate our medical staff how to recognize which patient that very good for them to have a genetic study and counseling. So in our practice, what we do, we have a public patient and also referral from the private hospital or also from the oncology part that need do the surveillance after the surgery. So basically in our setting, because we have limited staff, we have 2 breast surgeon in our center. So 200 patients at one time to come over in our clinic is very limited. So we have few minutes only to discuss about the genetic, and then I think it's a good practice to do all this genetic counseling and study, discuss with the patient. So actually, ideally, it's good when we talk about genetic counseling after we know that this patient, high-risk patient, triple negative, young patient, right? Bilateral breast cancer. So basically we have to recognize first. Then after that we will talk about to break the issue about the diagnosis of breast cancer is one more thing. But to go to about the genetic study is another difficult situation for us to talk to the patient. So we have to see how the background of the patient. If the patient is very, very educated and sometimes they can accept, then we will talk about the genetic. So at any time, actually, so even after the diagnosis, during the treatment, sometimes it will be, so the patient aware about the genetic, and then they will go for that. So we don't have any network or any workflow about genetic counseling. It's very difficult for us. Or even we are a breast surgeon, we have limited about the outsource, about the network, and even how to deal with the patient about the genetic counseling. Yeah.
Thank you very much, Dr. Senia, for describing the situation in government center and in the southern area. And yes, we take note that in terms of knowledge, both from the patient side and also from the clinician side, in order to move more into the discussions about genetic testing, that's certainly something we, as a country, we really need to look into, and definitely in terms of the network as well. Yeah, I think because now the use of genetic information is across all areas of the pathway, so it is maybe time for us to get that information in a way that is, like you say, in a busy clinic. How do we get that across in a
So basically, we don't have any person in charge on counseling about the genetic, or even we have volunteer from our oncologists. So only one oncologist that volunteered himself to counsel the patient. So whatever that we have, the patient, and then after that we will call him, and then we'll get appointment to see him, and then he will try to counsel the patient.
Oh, that's a very good start. Volunteer oncologist to talk about genetic counseling, but that's great. That's great. That means that it is starting, and I think maybe driven by the need, right? So that moves on nicely then to our next two speakers who are oncologists. So Dr. Adila, you are more in Central, so you are in PPUM. So what sort of challenges do you see then in trying to talk about BRCA testing in the oncology setting?
Good afternoon, everyone. So thank you for the question. So I think I have to say I'm going to talk from the patient perspective and also from the clinician perspective. So from the patient perspective, the cost is actually the biggest issue. And as we know, the BRCA testing can range between 2,000 ringgit to 3,000 ringgit without the treatment. And majority of patients, they are self-paying, they haven't got any insurance, and that can be quite burdensome. So that is actually the biggest challenge for the patient. Other than that is the awareness. So patients have been given very little information about the BRCA testing, and therefore, it's hard for them to decide whether or not to proceed with this. And also, if they do, they have that anxiety and fearsome to go ahead, and also the cultural belief. Some patients believe that if they got genetic abnormality, it caused a lot of stigmatization and also caused a lot of psychosocial anxiety for the patient and also for the family. From my perspective as a clinician, again, it goes back to the cost issue. Cost is a limiting factor. As we know, as I'm currently working in the government hospital, it is not funded by the government, so therefore the cost has to be covered by the patient themselves. Then this is the limiting factor. Also, time is the factor. As we all are working in a busy clinic, so therefore, we have very little time to explain this to the patient. We have very little time to counsel the patient about the importance of having BRCA testing. Other than that is BRCA testing is not part of the standard practice among clinicians. So there is a variety of practice among clinicians, across Malaysia. So therefore, some clinicians may or may not do the BRCA testing as a standard practice. And again, there is also a limiting factor in terms of the skills. So not all clinicians are trained to actually give genetic counseling. And I think it's the anxiety and the fear of giving, the information and the consequences about it. So therefore, patients are not being, not being counseled about it. And also, as we all know, we have very, very few genetic counselors in Malaysia. So again, that is one of the challenges. And last but not least is the accessibility. So I work in UMMC, so therefore we do have that, access. But however, there are some cancer center in, in rural areas which they haven't got the access to have the BRCA testing done. And if they do, it can cause a delay in the diagnosis and treatment.
Yes, in a nutshell. All of the issues, and very nicely put. Thank you very much, Dr. Lina. In a sense, that's why we are having this forum and discussions, so that there is a feedback, and also sort of in order for us to pull out the main themes, which I think we all are starting to see now, and some of it will be addressed in the second session that's going to be moderated and chaired by Prof. Aisha. And yes, and I think most of us who work in the field will recognize that these are some of the issues, and hopefully we are able to overcome it as we work together. Moving on to Dr. Kylie, changing the direction of the discussions in a way. Hello, Dr. Kylie from the North. I believe that you've had quite a lot of experience working, discussing about genetic testing, BRCA testing with your patients. My apologies, I'm looking at this because this is the nearest screen with you. I'm not sure where to look. So from your experience with the patients, how do you think the patients have been taking these tests? In your opinion, how do you think they've been accepting it when they proceed with the testing or not?
Okay, you can hear me okay? Great. So I come from a different practice setting. So I work in a private setting. Most of my patients are insured. So costs, sometimes it's not an issue. A lot of the time it's maybe an issue, but it's rarely a problem for my patients. The next thing is the main issues that I face with regard to BRCA testing in my patients is really their acceptance to do the test or not. And from my experience, it does take a lot of time to convince patients to do the test. It's not a single visit. And fortunately, in a private setting, I do have the time to break down those layers and to eventually persuade them to do the test. Secondly, many of the patients that I see actually have high-risk disease and will require some sort of preoperative therapy. So if they have neoadjuvant chemotherapy, whether it's for triple-negative breast cancer or not, it gives me more time to talk about these things. And for some insurance policies, they actually do cover for the test. So cost-wise, it shouldn't be a problem. I do have access to a fantastic genetic counselor, and I'm looking at her now. She's Miss Yoon. Okay, so my patients actually do a virtual consult with Miss Yoon, so all the way from northern Malaysia or even in Indonesia. So it works out quite well. When it comes to the reason for testing, and when I tell them that it affects their treatment, generally it's a lot easier. But when they can't afford the treatment, then often they will ask me, so why test? Then I have to talk about, risk management and all that. And then it's a plus minus thing. So some will go ahead and some may not. So but otherwise, the uptake is pretty okay in my setting.
Thank you, thank you. Thank you for some of the feedback on how it's been coming along with you and your patients. So that is another area where the purpose of testing is actually more for treatment purpose. That seems to be one of the pros that the patients see more towards too. But if the cost of the treatment is not something that they can manage, then that takes away that pros in a sense. However, I think it's really important for us to know that depending on why the testing has been ordered, be it for treatment or be it more for risk management, there are pathways to what we can do with the patients after that. So I think we have run out of time for these sessions in terms of the questions. But this is just actually only the start of all of the questions. This is really to get the conversations going among all of our experts here. So thank you very much to our panelists here today. That has put a lot of information on it. We actually have quite a lot more other questions, but we'll try and deal with them maybe in the later session, Prof. And I think with that, I will close this session. We will take a short break and over back to you, Dr. Teck.
Thank you very much.
Prof. Park, are you okay if I ask you a question?
Okay. Can you hear me?
Yes, I can.
Yes.
I
Yeah,
just
yeah.
wanted to pick your brains on certain topics, certain subtopics around this issue with BRCA mutations. Yeah. So I just wanted to know how you decide for olaparib in the adjuvant setting. Let's say for patients with ER low disease, like the 1 to 10% patients who you kind of think that this is behaving like a TNBC, but let's say if they don't fulfill the Olympia requirements for ER positive disease. Let's say if they got N1 disease or they have a CPS EG of less than 3, right? Yeah, how would you tackle that?
You really point out your good point. Whenever I meet the AstraZeneca people and also the Pfizer people, I keep saying them. Actually, during the Mediola clinical trial, I keep saying that you need to include another population, like as you said, the low ER, such as like regarded as the TNBC. But they blame the FDA. FDA does not allow like that. So if we really want to do that, we need to kind of revise the ER positivity, like updated, like so, previously 10% or more ER positivity only regarded as a real ER positive. But it's revised only just nuclear staging 1% is now is treated with the ER positive population.
Yeah.
That's a pity. And also whenever I see my kind of a colleague, I'm sharing my thought like you, and then also you need to the kind of a PAM50 thing. If you do that, just to turn out to be a basal like not luminal A. So keep saying that I really agree with you pointing out. And also I actually published the kind of a low ER population really acting such triple negative behavior, not luminal breast cancer population. And also it's a kind of a dynamic BRCA mutation patient to show those less relatively low ER, not actual ER like 5 OLED score 5 positive and PR negative like that. And then when we treated also ER suppression with endocrine therapy, they showed that turn out to be like TNBC, like the endocrine depletion. It's a real dynamic feature when we do the repeated biopsy sequentially. So you really picked up real good point. So we maybe expand the kind of population that, so less than 40 only can take care of the germline BRCA mutation test in Korea. Not,
Yeah.
not like the TNBC, because of they show the ER positivity.
Ah,
Thank you
Ah,
very much, Professor Park and Kylie. I think the question is so good, and I just wanted to ask you a question about the age. Because we know triple negative anybody less than 60, and when we want to look at ER positive patients, we are looking at the high risk in population. If you look at the Olympia, I think the mean age was 45 or something like that, and then the ranges up to 50. So who are we going to choose to test BRCA if they are ER positive? Is there an age cutoff point?
yeah, as you just mentioned before, actually NCCN endorsed all the breast cancer population. Yeah,
if
all the breast cancer, once diagnosed as breast cancer, they should receive germline BRCA 1 or 2. That's my message,
If we have
actually.
cost issues,
Yeah,
then
cause
what do we
issue,
do?
yeah, so when the patient who can have a ER positive to negative population, it's still less than 40, but I think we need to expand to 45 or 50
Mm.
at least. Thank you. Thank you for.
that's a great discussion. Very difficult topic, and also
Yeah,
it affects how we actually treat these patients in the neoadjuvant setting as well.
yeah,
Whether
yeah,
do we use pembrolizumab and all that for the
yeah,
ER
yeah,
really
yeah,
low patients? Yeah.
yeah. Thank you for good discussion.
Okay,
Thank you,
thank you
Prof.
very much for the exciting talk. We will have to resume our next segment. Thank you, Professor Park and Dr. Kylie. Our next segment is on integrating germline BRCA testing into routine clinical practice. We will now invite our next speaker, Professor Noor Aisha Muhammad Taib. She is my mentor and also a senior consultant breast surgeon from University Malaya Medical Center, UMMC, Kuala Lumpur, Malaysia. She is currently the head of Cancer Research Institute, and she has about 200 publications in peer-reviewed journals. Her areas of interest are strongly correlated with patient care and outcomes. She is the leader of the Management and Quality Technical Committee in the Greater Petaling City Cancer Challenge and City Executive Committee member. CCAN supports cities around the world, and as they work to improve access to equitable quality cancer care. Without further ado, I welcome Prof. Noor Aisha to deliver her talk on pragmatic approach in mainstreaming germline BRCA testing, the MDT way. Welcome, Prof.
Thanks a lot. Thank you, everybody. Assalamualaikum warahmatullahi wabarakatuh.
Yes,
So let's
the
go
Olympia
straight into
study,
the talk.
which is a phase 3 study looking in.
Oh, I think that was me recorded earlier in another meeting. So what are we going to talk about today? So I would just say that Professor Park and what we discussed before really exemplifies why we are here today, why we need to think about giving better access to genetic testing in our patients. So what we'll be talking about is mainly what is mainstreaming, what are the barriers and facilitators, and how do we actually get onto a multidisciplinary team approach to getting access to genetic testing. So what is implementation science? It's really a science to understand the barriers and facilitators and design and test different strategies to scale evidence-based practices. So I think all this while, I think in Malaysia, we always hear new studies coming out. Unfortunately, we find that our clinical practice don't change very much. So how do we move on to improving care for our patients? So really traditionally, hereditary cancer is usually identified not in the urgent situation. We refer them to clinical genetic services where they get pre-test genetic counseling, and then the test is done, and then post-test genetic counseling is all done in the genetic service. But when we talk about mainstreaming, it actually is not new. It started off in 2014. So can you imagine that's about 8 years before? And it is really in the domain of the ovarian cancer management. And we know that what has been performed for this is mainstreaming means treatment focused genetic testing is actually performed by the primary doctor treating the patients. So there has been many evidence and practice that has been published to show that it works. So mainstreaming is actually done by primary doctors treating cancers, and there are known mainstreaming um, testing criteria that is very much related to the treating doctors. So for example, you can actually use this testing criteria or the MCG testing criteria to actually find about 10% of your patients that may actually be BRCA positive. And in Malaysian clinical practice guidelines, it's already there. So, but how many of us actually practice this? So this has come out in 2019. So, but however, I think none of us have actually done it. We've still used our friendly genetic counselors and geneticists to help us with this process. So, you know, I think this talk may be for breast cancer treatments, but we know that the domain is actually expanding. So we have it in ovarian cancer treatments, and metastatic breast cancer treatments was even back in 2018, for pancreatic cancer in 2019, prostate cancer in 2020, and now because it's treated for early breast cancer, not metastatic breast cancer, that is why I think half the panelists today are from the breast surgery fraternity, because we may be the biggest barrier to accessing genetic testing in our patients. All right. So what do we understand about the attitudes and knowledge of treatment-focused genetic testing in our patients? So this is a study done by Ms. Rifhan, our genetic counselor in UMMC, when she was doing her master's. So the major challenges in implementing this is the limited knowledge and the coping of breast cancer patients and their genetic literacy, the cultural aspects, as well as attitudes towards risk-reducing surgeries and the cost of testing. So this is a 20-person qualitative study where the patients also told us that they preferred face-to-face discussion with their treating doctors. So not genetic counselors, not geneticists, but their treating doctors. And hence, we should really try to improve our education as well as breast cancer health itself for our patients and improve their genetic literacy. And we could only do this through education. All right. What would be the attitude and training needs of oncologists and surgeons in mainstreaming? So this paper was published last year. I think it was funded and led by Cancer Research Malaysia. And what we found in the study of a survey of 21 oncologists and 32 of surgeons in Malaysia is that 77.4% of them expressed interest in providing breast cancer genetic counseling in their clinics, but 85% still preferred to refer to a genetic service. And they found that the barriers were mainly patient affordability to the test and the PARP inhibitor therapies. So we know that these tests are expensive. And one more thing is that the lack of confidence among the respondents to communicate information about genetic risk and genetic testing, particularly when patients have poor health literacy. So definitely there is a need for education and training. All right, so now we go on to how we would be able to perform this in our practice. Is really through the multidisciplinary team approach. We know that a multidisciplinary team is consisting of professionals from different clinical disciplines, and by discussing and creating a concordant outcome to the treatments that's needed and the treatment plan, then only we can provide the best treatments for our patient. So actually in our clinical practice guidelines as well as our strategic cancer control plans in Malaysia, we have always put up MDT as one of the main approaches to improving the quality. However, do we do it? So I think in most hospitals in the bigger centers where they have all the subspecialties, MDTs may occur. And we know that we are all very busy, and how it is being implemented, we really don't know. So we really need to understand this, because in order for us to move forward, we need a team of doctors treating our patients. And the common barriers we know about implementing MDTs would be lack of support from the leadership team, which could be the management of the hospital, Okay, and of course, professional hierarchies sometimes that discourage active participation, ineffective communication between different disciplines, insufficient human resource, increased workload that leads to lack of time and clinician burnout, and inequity in access to health services due to the geographical and economical limitations of our patients. So one of the most important part of the MDT is actually the lead clinician. So effective leadership is crucial in ensuring the functioning and sustainability of the MDT. So each center should identify an MDT leader. And I think for breast cancer, most times it's the breast surgeon. And I know some of our panelists today have been championing in their hospitals in getting things done. And I hope that we will be able to improve the care further with creating more champions around the country to do MDTs for their hospitals. But we know there are limitations because we may not have all the specialties in one hospital. So how do we know who are the specialized people that we need in the team? So there is a document that has been produced by the best practices, by the Breast Cancer Greater City Cancer Challenge MDT project that was published recently. And these best practices would help people to sort of plan how they would do it. And you can see the core team members is the simple group of people that we have most of the time. We have the surgeon, the clinical oncologist, pathologist, radiologist, an oncology nurse or breast care nurses, as well as an MDT coordinator that helps with the logistics. So where does the genetics and hereditary counselors fit in here? They fit into the non-core members. So they don't have to attend all the MDTs. And one of the things that we would like to do for this project is to even expand the access of the geneticists to other hospitals by producing a virtual MDT, right? So you can read more from this document and you can see that actually MDTs are performed for different functions. We know at diagnosis, we would have an MDT to discuss whether the patient needs to have surgery or neoadjuvant chemotherapy. And I think the question Ms. Yoon asked earlier, when should we introduce BRCA testing? It does look like because we need to get the test results soon. Hence, maybe this test should be even brought forward at the point of diagnosis. That means when we know a patient has the risk factors or the criteria for testing during the diagnostic period, we should be able to actually offer genetic testing counseling at this point. Okay, but of course we know that during surveillance of cancer patients, we do need to talk about future risk management of future cancers and all that. So BRCA testing is really done throughout the whole journey. But in order for access to early breast cancer adjuvant treatments, it seems that we need to do this test at the point of the first MDT where we are making the diagnosis. Okay, so there are many other things that we have in this document, including implementation plans. Like if you all the champions out there who want to start their MDTs in your hospitals, there is some form of guidance that we use, the quality implementation framework, and this document can be, you can contact me for further information on how to get hold of this document. Okay, so the last slide I have here is really to introduce to you the fact that I think, as we know, educational needs, training needs, and one of the most important barrier for us is the lack of confidence in actually performing mainstreaming. And of course, the lack of geneticists and genetic counselors in access to for us to access in all our hospitals. So this is a 10-week program which consists of 10 modules and is all run online and paced at the user's own pace. Okay, so we have, as you can see, there are 10 modules covering from introduction, blah, 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 even the genetic testing, the process of mainstreaming itself, because, you know, we have to go back and make it relevant to our practice. How do we make it simple, straightforward? And we will have this in this course. We will also touch on shared decision making. And of course, the last part is the implementation part. How do we implement the service? This will be put into into this Future Learn platform for everyone to access. And after that, it would be supported by the Cancer Echo with limited sponsored BRCA tests. So this limit, you see, the biggest issue we have is the cost of tests. So I think we are looking forward to working together with the industry and academia, as well as all the services providing breast cancer management, to improve the access. I mean, it will not be free, but it will probably be at a discounted cost to the patient for us to get used to practicing mainstreaming in our own clinical practice. So I think that was really my last slide. And we can actually convene to our panel discussion. We can spend a longer time in the panel discussion, discussing about the implementation in other parts of Malaysia, because we've covered southern part just now. We've covered Penang, and now we will have some opportunities to meet people from Sabah and Sarawak, actually Sarawak today. Okay, and maybe I just wanted to put a blip up. What is included in that module is also how to manage risk. And we have patient decision aids that have been developed by our students in University of Malaya. And there are two, so this you can actually access it even now online. You can go to the website Brakada, and the other one is developed by our now no longer PhD student. She's already completed her PhD, Dr. Hamiza. And these patient decision aids are available, and we will make it accessible during the course. And in UMMC, because of the issues of ethical, legal, social aspects of genetic counseling and testing, I think we are also thinking of making it a privilege way of doing things, so that we know that the people who actually provide mainstreaming are well trained before they actually provide it. So with that, I think I'll pass over the microphone back to Dr. Tay, and I will just move on to the other side.
Thank you, Prof. Aisha, for the enlightening talk. Prof. Aisha will go to the stage. She will be moderating our next panel discussion. I would like to invite 4 panelists up on stage. Dr. Maya Mazuin binti Yahya, Dr. Adibah binti Ali, Dr. Ng Ji Yi, and Miss Yun Sok Yi as well. I will now introduce Dr. Hold on. Dr. Maya Mazuin. She graduated from University College Cork, Ireland in 1999 and completed her Masters in General Surgery from University Science Malaysia in 2007. Her area of expertise is general surgery and breast endocrine surgery. She's a consultant breast and endocrine surgery from University Science Malaysia in Kelantan. And the next panelist is Dr. Adibah binti Ali. She graduated in UNIMAS in year 2002 and completed her Masters of Surgery in UKM in 2012 and fellowship training in breast and endocrine surgery in MOH Hospital, Putrajaya, and also Sheffield Teaching Hospital, United Kingdom. Her area of expertise is also in breast and endocrine surgery. She's a breast surgeon. And the next panelist is Dr. Ng Ji Yi. She is the only oncologist in this panel. She completed her medical degree from UKM in 2011, Masters of Clinical Oncology in University Malaya 2021, and she is actively participating in clinical trials focusing on upper GI tract malignancy, colorectal, and breast cancer. She's also leading the cancer genetic clinic in SGH Kuching, collaboration with Genetic Department of Hospital Kuala Lumpur. Prof. Aisha, I hand the floor to you.
Thank you, Dr. Tay. So I think we had a good session earlier, the first session, and we understood a little bit about genetic testing and counseling. So maybe we can start off to get a bit more familiar about the genetic counseling and testing aspects in Malaysia. Maybe Ms. Yun would like to clarify further.
Okay, thank you very much, Prof. Aisha. So I think maybe just to start the conversation going. So the whole point of using genetic information, and if we talk about BRCA testing, is either for treatment or for risk management or for both. And the reasons to test is important because who gets tested then becomes important. If it's for purely for treatment, decision making, then you don't even look at the criteria. But if there's an element of risk management, then you have to look at the risk criteria because you need to assess the level of risk in the individual or the family. So because of that, then the discussions are also tailored a little bit different. So that's where the concept of genetic counseling comes in. So I say concept of genetic counseling because genetic counseling essentially means empowering the person to make some decisions about finding information about their own genetics, right? And that information can come from anyone that is trained appropriately. So usually, traditionally, it's always been genetic counselors or clinical geneticists, and that's why we have a lot of very in-depth training. But because the growth of the use of genetic information is so fast, the fraternity cannot catch up fast enough. So either there'll be a big gap, that means people just don't get their information, or they get their information wrongly, which is even more dangerous. So there needs to be a way of which some form of genetic counseling, and I put it in inverted commas, basically helping some individuals to understand that genetic information, not necessarily to be the same in depth, but at least that is a prompter before they do a test. So that is the ideal goal, that someone, before they do a genetic test, they at least understand some basics about it. So instead of just having a test ordered for them, or they ordering it themselves. So I think in Malaysia, again, because of some of the issues that were brought up, there needs to be some pathways to improve that information giving and understanding for our patients and their family members.
Okay, thank you. I think that's something that most doctors are wary about, having to do that genetic counseling. Do you have any proof that it has been done in Malaysia? Maybe you can tell us a little bit more about the experience in Malaysia.
So when we did the MAGIC study, which was essentially all of the mainstreaming ideas that were presented, and in many, many different hospital settings, both in government and private settings, but in a space for ovarian cancer, which is different from breast cancer. So, but what we have shown across the board is that patients, that it was meant to measure psychosocial outcomes, whether there was a difference from the patient's point of view, whether they were more distressed and so on. There were some measures. There wasn't actually very much difference between both arms of those who were either counseled by their own primary caregiver, either oncologist or a gynae oncologist, or through a genetics clinic. So we know that it's, in a sense, kind of safe because the patients haven't shown to have additional psychosocial issues. But of course, that was a study where it was primarily to look at that. So there was no cost involved and so on, which is a whole different ballgame in real world situation. But feedback from the clinicians was pretty much close to what was presented by Prof. Aisha. Clinicians, after training, given the appropriate support, felt that this was something that they could do if they had to. Meaning if it's not easy to reach a genetic service, then it's something that they can do.
Okay, thank you. So I think given that background, and we've heard from Penang and Johor, now maybe we should listen a little bit from Kota Baru, as well as from Sarawak. Okay.
Okay, Assalamualaikum and good afternoon. Well, I am practicing in Hospital University Science Malaysia. You know that Kota Baru has two hospitals. We have GH, which is HRPZ2 now. Dr. Amy is there, and I'm in Hospital USM. It's it's correct. I'm probably guilty with whatever Prof. Aisha had said in the talk just now. The rate limiting step is the surgeon themselves. I mean, for me, yes, because probably like Senia said just now that in a busy clinic, and all we need to get from the patient is the diagnosis and start treatment, and we forgot altogether about what else can be done for the patient. I asked Junaidi in HFZ as well as our gynecologist in hospital USM whether they do send for genetic testing for ovarian as well as the breast cancer in HFZ, and they said that they do send for 2 to 3 a year. Because, but they don't know whether proceed or not with the testing itself, because they send for counseling first. And Dr. Prof. Pazudin from Gynae said that they rarely send because of the cost limit, the costing issue. And I welcome this mainstreaming because yes, I think we need to be informed and more involved about it. So, you know, whatever the outcome and whether it can be risk management or treatment will be later on. However, maybe it's even worse from our side to have this to be at about 2,000 to 3,000 ringgit Malaysia, because you know that even for us to, you know, for 2 plus HER2, sorry, IHC 2 plus HER2 is quite difficult to ask the patient for, you know, testing, because it's not quite standard in our hospital as well.
So I think we have to understand the health system is not perfect at the moment, and access to even tests like HER2 testing may be a problem also in some parts of the country. So I think maybe we can also hear from the Sarawak point of view. Maybe we can start with Dr. Adiba first, and then we can move to Dr. Eng to see what is done in Sarawak, and maybe later we go for another round. We can think about what could be the ways, the first thing that you need to do to maybe start in your hospital, you know. And I'm sure Sarawak have done MAGIC study and some of the other studies as well. So maybe Adiba, you want to start first?
Okay, right now, Sarawak, as everyone knows, is a very large state. It's as big as a Peninsular Malaysia. So we only have 3 surgeons in Sarawak General Hospital, and other parts of the state will be managed by general surgeon. So I agree that mainstreaming is very important, because it's not easy for us to send our patients for only genetic counseling in KL. So if we can perform the mainstreaming in our local center, so it can actually help to burden the load. But however, we still have to think about our patients. They're very still selective who to refer, because for us to get them to perform the surgery in the affected breast is a bit difficult to convince them. So I sometimes I would think that it's not easy for us to convince them to do contralateral breast. So that's another question, why test? If patient not keen for risk reduction surgery, if patient cannot afford to perform, to do for the targeted therapy. So back to the question, why test? So if it's just for prognosticate, so I think that it may not enough for us to think that this genetic testing should be implemented in all patients. So it is still a bit selective to our patients. Yeah, but I would think that standardize the way of how are we going to mainstream is still important, because there are certain patients are still now they are quite aware of importance of genetic testing and subsequent management for those BRCA positive.
Yeah, I think you picked 2 main issues there. One is the cost. Again, it's not just cost of the test, the cost of the treatments. So that's one issue that maybe Dr. Eng can also say a little bit about. And the other one is really about, you know, patients do not want to have anything done if everything is normal, right?
Yeah.
Yeah. So maybe why don't we hear from Dr. Eng first, and then maybe later we can hear a bit from Miss Yoon. Maybe she can tell us a little bit about patients' perspective in risk management in terms of surgeries. Maybe Dr. Eng, do you want to talk about the services there?
Okay, thanks Prof. Aisha for the questions. So actually, yeah, Sarawak General Hospital currently we just set up our own cancer genetic clinic with the help from the clinical geneticist from Hospital Kuala Lumpur. So the reason why we set up this cancer genetic clinic in Kuching is because the main problem is the access issue. Because we in the East Malaysia separate from the West Malaysia by the South China Sea, so we definitely got no access to genetic counselor, very difficult. So and then like during normal clinic in oncology clinics, the oncologists are very busy. We got a lot of patients. So and then every time when patient come, either new case or when they had their chemotherapy, usually the information that the patients get will be overlooked on that day. So we think that is we prefer another session just to counsel patient on this genetic counseling. So that's why we set up this cancer genetic clinic, and because we just start to set up this, so now like we only have this clinic like once in 3 to 4 months time, and then a clinical geneticist from the HKL will fly to Kuching and then to basically actually train us to provide the pre-test counseling, and of course later on better to have a post-test counseling as well, where we, I think as oncologists, mainly our problem is provide those post-test counseling, especially when the patient's result come back as this one variant of unsignificant, uncertain significant, yeah, the VUS part, yeah. So.
Okay, so at least there is some movements, right? Because I think people respond to the needs, and then you found that it's difficult to actually do it within the service that you have. So you all have started another clinic. Yes. So that is something that it can be used as an example, of how you respond to the needs. So maybe if you would like to chip in, both of the surgeons, Ms. Maya dengan Ms. Adiba, would you think of a way to simplify the pathway that is currently being done, if you could provide something, maybe like what SGH is doing? Would you have any suggestions?
Okay, yeah, this is a very, very good step. I think welcoming to help. We should have a better network where a clinical counselor or geneticist will be, genetic counselor or geneticist will be at the tip of our finger. So, I mean, whenever I need to consult, it will be available. And yes, we probably can be partly trained as well to, give the information to the patient probably. As well as maybe Ms. Adiba said just now, our patient also was like, where to convince them to have a treatment also is a hard labor already. So maybe, yes, we can take a big step as well to inform them that this is probably needed to guide treatment as well as guide their risk management in the future.
Okay. Yeah, actually, it's a good start for us to have the geneticist visit every 3 months. But I will still think that the first team that usually the breast cancer patients are us breast surgeon. So those actually who's seen by oncologists, they are actually have undergone and completed and diagnosed. So it will be integrated because we have a very good network with the oncologists. We still have MDT every 2 weeks. So this is where actually we can gather and make it in integrated practice and standard practice. We still have to start somewhere rather than practicing as the same as what we had before. So yes, I agree with that.
I think I hear the frustrations from the surgeons, because sometimes the patients, they're just not ready to move forward. And we also found that in the study that patients were not, when you talk about genetics, they're like still talking about their diagnosis. So what are your thoughts about psychosocial support? You know, I will just touch a little bit on this, and then maybe Miss Yun can make a roundup about our psychosocial needs of the BRCA patient. Maybe you can comment on, let's say, psychosocial support that is available to our patients now. Is there a problem?
Okay, to say the least, that probably our patients are quite alone in their predicament, because you know that being mostly Malays in Kelantan, right? They probably have maybe 50% of the say in whatever decision is made for them. You know, you can see that most of them are actually the strength of the family, where they think that if they are not there while receiving treatment, the rest will not function. It's true, actually. And we do have, you know, we do have counseling support for them with our liaison psychiatrists all. However, probably it's not as good as the support from their family themselves. I mean, I could say that yeah, majority of our patients are quite alone in their predicament. When I say that they are actually, you know, maybe less than half of them will have their husband come with them to consultation.
All right. Yeah. Before we go for the patients, I think among the clinicians we have to be, our knowledge on the psychosocial support have to be more strengthened first. It's not, we are not trained yet how to face and how to answer them if they need one. So I think at the level of our side, I think our side has to be strengthened first by all this training. So yeah.
Thank you very much. And that is the actual real world. That is currently what's happening in Malaysia across the board. Firstly, it's the cancer diagnosis itself. And then, of course, this is an additional layer. So just on the side, there are actually more and more genetic counselors being trained. So we do have a local course in UKM, a Masters of Genetic Counseling course, which is excellent because as counselors, if we train and we practice in Malaysia and we are Malaysians, we speak the language, we understand the culture. And that is a very big part of the psychosocial support. So on the one side, we are training more and more genetic counselors. So hopefully they will be in the system. Ideal goal, each center has one genetic counselor to support the clinicians. Ideal goal, we want to reach that. But when it comes to patients, right, from what we see as a perspective, the clinicians are their source of the very practical information. Do this, do this, do this. This is for your treatment. This is what the result is. And because of the way things are, there isn't enough time to dwell more into it. So that's where the counselors come in, and it can be from social worker side even. It can be from the counselor side, not necessarily be just genetic counselors. So we do need to have that network for them. The issues for patients when it comes to genetic tests, it's always the fear of passing it on. It's the inheritance part. Maybe the children next time cannot get married because they are high risk. Some of these are very big fears. So we need to reinforce the other side of it to counter the fear. Something along the lines where we empower your children. At least they know now there's something they can be done. They don't have to go through what you have gone through. Some of those, but those take time. And that's where you need to have that additional layer of support. So like Prof's diagram, your core, and then you have the non-core. The non-core in the MDT is to pick up all of these other issues. So when we talk to the patients, we spend time with them. Most of the time, we are listening because they need to tell us what their issue is.
sometimes just being able to tell someone that is not in their space is very helpful. So hopefully with that sort of networking, we can provide that layer of support. But the primary information does come from their caregiver, the main clinician, because they need to know the main facts first. And that can be done. Then you have the additional layer, which is for the support part.
Okay, thank you, Ms. Yoon. I think time is really mencemburui kita, so there's like 1 minute left according to our timekeeper. So maybe I could just sort of summarize that obviously the interest from the primary care doctors is very, very strong. What we need is to train, network, not just about genetic testing, it's also about counseling, providing psychosocial support, and hopefully by networking, the world is now virtual. We don't need to be physically present. And through these MDTs, all those non-core members that you do not have in your hospital can be provided in a way through these virtual meetings. So hopefully, I think, we have to close the session, but I'm sure this is not the last day that we will be talking about it. And we hope that all of you would be interested in the professional development course that we will be providing next year. And hopefully we have new champions in many parts of the country who will bring forward the testing to our patients. So with that, thank you very much to all our panelists. Maybe give a big hand of applause for all of your participation. So with that, thank you very much. I pass over back to Dr. Teh.
Thank you very much, Prof. Aisha, and all our 4 panelists. I would like we are in great time. Thank you to our timekeeper as well. Thank you all for attending today's forum. In a nutshell, mainstreaming genetic testing could be the key to improve access to access and pace of genetic testing, as well as refocus resources. Therefore, I would like to share again the slide of our upcoming 10-week short course module with all the listed week 1, week 2, all the way down to week 10. This module does not only educate us, it will also help clinicians implement a new service in their routine practice. Therefore, I think this will be very beneficial to all those who have to deal with patients with risk of genetic diseases. We care about your opinion, so please give us some feedback. Thank you again for attending today's meeting. We encourage you to connect with us. Thank you and enjoy the rest of the weekend.